Cochran-McClain. She is the Chief Policy Officer of the National Rural Health Association. And here today, she's going to speak to us on recruitment, retention of providers and critical access staff. We know what a hot topic this is and how much we definitely need more information. You'll be able to find Carrie's bio in your packet. So Carrie, I'm going to turn it over to you at this point. Thank you.
All right. Well, thanks so much. Let me just get my slides up here and running for everyone. Okay. One quick moment. If I can make the Zoom room work for me here. Okay. So thanks, everybody. I'm so excited to be with you here today. And love the great work that the Indiana group does in partnership with the National Rural Health Association. Before I get started on my presentation, I want to do a full disclosure for you all. I am a policy person. I have worked for almost 20 years at the national level on healthcare issues impacting safety net populations, especially with rural populations. And so what I have to talk with you today about is kind of what we're doing at the national level around rural workforce, some resources that I'm aware of at the federal level that you might be able to tap into, and kind of some strategies, best practices that folks have told me. But full disclaimer that I have not been in your shoes. I have not tried to kind of recruit someone in the same position that you all are in. And so my job is to have a dialogue with you today and kind of tell you what I know. And I'd love to hear from you about what you think we could be doing at the national level to better support workforce recruitment and retention in our rural facilities. So with that, let me see if I can drive here. Hopefully you all know about the National Rural Health Association, but if not, just a quick moment on us. We are a nonprofit, nonpartisan national organization. And our aim really is to improve the lives of folks living in rural America through kind of access to healthcare. And so we talk a lot about work in our advocacy space, communications, education, and research to talk about how we can really raise the voice for rural health and rural healthcare issues at the national level. We have 21,000 members across the country, and our membership is a very broad umbrella, and we all kind of have that common interest in rural healthcare and access to care in our rural communities. So from a government affairs perspective, because that's my job as the Chief Policy Officer, I work with our government affairs team. My role is to really kind of lift up what I see are our three primary kind of buckets of activity within NRHA. The first is investing and supporting a strong rural healthcare safety net. So talking to all of you as critical access hospitals, as providers out in the field, kind of that frontline infrastructure of folks taking care of individuals in our communities. What do we need to do to be supporting you both in the short term and in the long term as our healthcare system continues to evolve? What we're talking about today is the issue of workforce. I will say is probably the issue I hear the most about from our association members. So we spend a lot of time thinking about what we can do to build up a strong healthcare workforce in our rural communities and reduce some of the kind of ongoing shortages many of you have faced. And then last but not least, we spend some time, a fair amount of time, talking about this issue of declining health outcomes and life expectancy in rural communities and the inequities that creates between our urban and suburban and rural communities, and what do we need to do in terms of policy and programmatic solutions to address that. So like I said, today I'm going to be talking about workforce, where I see some opportunities in the policy programmatic arena in terms of making change. and then what resources might be available to you all to help you with your work, and then strategies, and hopefully a conversation. And I know that we are in kind of this webinar format, but I do want to make available the opportunity to kind of be able to have a dialogue and questions and chat as needed and as you guys have thoughts. So please feel free to use the question and answer and chat features. I will kind of monitor those as I go along here. So in terms of our rural healthcare workforce, I just wanted to do a snapshot of recent data that we have kind of on what this looks like in our rural communities. So what you see here on the screen is a snapshot of metro or our urban, suburban areas and non-metro or our rural populations, and kind of what our provider ratios look like in each of those settings. And as you can see, we in rural communities are much more dependent on folks like our nurse practitioners and physician assistants and advanced practice nurses to help us get our care and our primary care. And so I think that's one important takeaway of this. I think another takeaway is that we just have a lot fewer providers in our communities than some of our urban and suburban counterparts. And so starting off from that kind of recognition of, we know we're operating from a deficit, we know workforce has been a perennial problem for rural areas. And so what can we do to address some of that? And I'm lifting up a couple of recent research publications that have been funded out of the Federal Office of Rural Health Policy, because I think it's really interesting to think about kind of how our workforce is trained and distributed across the country. We have data as of 2019, which I know the world has changed significantly since 2019. But a really good sense of kind of our primary care workforce, what it looks like across the country as of 2019. And we know that there are definitely deficits in a number of our specialty areas in our rural communities, and that those shortages are more significant than in rural areas. So we just have like kind of some data there that can share. This is data kind of lifts up about some of the specialty concerns, and in particular, we at NRHA have spent a fair amount of time talking about the issue of obstetrical care, and then closely tied to that is general surgery, because we find once you lose like the capacity to do general surgery, you frequently lose capacity to do OB and vice versa. So they're closely tied. And so this is another kind of need area that we're looking at, in addition to a range of obviously other specialty areas. We also know that we are in rural America much more reliant on family physicians to provide a broad range of healthcare services. And so we spend some time thinking about kind of how we're recruiting and training those family physicians, and how we grow that workforce to be reflective of the population it's serving, whether that's geographically or racial and ethnicity, but thinking about kind of how we recruit and distribute those providers to our rural communities. And so a study out of the University of Kentucky in 2022 kind of looks at some of those issues around diversity in our rural and urban settings. And then there's a group they're a range of academic institutions, including the University of Washington, that are really thinking about how do we build our pipeline? What data and evidence do we know? What best practices do we know to help us build kind of the pipeline of providers to our rural communities? And I'm just sharing that they have a whole number of studies that are in the works there. And recent findings that they had, which I think most of us know, but it is nice, especially from a policy perspective, to have the data available, shows that it really is true that graduates from rural backgrounds are much more likely, over 4 times likely to choose rural practice. And then that piece that we hear a lot about of the importance of training in rural communities. Graduates that train in residencies in rural communities are more than 5 times likely to practice in those settings, and stay in those settings in a longer term. And so this is important as we really talk about placement of these individuals, getting that experience in both kind of the formal training in through residency and other programs, but also I would say some of that kind of pipeline early exposure is really important to bring our students from rural communities back to our communities to be practicing in our healthcare facilities. And I think this shows you a little bit about kind of, while we know this training from the previous slide is really important, this shows you a kind of what it currently looks like in terms of actual breakdown of residencies. So one of the things I spend a lot of time thinking about is how do we grow that residency capacity, both in terms of the number of slots allocated to our facilities, the infrastructure around supporting the actual residency program, and the Federal Office of Rural Health Policy has a grant program that helps think about that, how we grow that actual resident capacity. And then also, and important to you all, is how do we relieve some of the workforce pressures on site so that they are able to precept and actually host students in trainee kind of settings, knowing that time you take away from clinical setting to time you spent with students is time you take away from the clinical setting. And so thinking about how we support our preceptors, both for med students, but also obviously RNs and APRNs and others. And, you know, this earlier data talks about kind of the training specific to family residency, but we see this theme of the importance of rural training in our physician assistant and nurse practitioner programs too. But we also see these programs being able to offer a lot more clinical training opportunity. And a survey, again, this group that's the rural prep group did a survey looking at physician assistant training programs. Vast majority offer some kind of rural training, some requiring some or all of the training to have a rural lens. And then similarly, in our nurse practitioner sites, there is a high number of NPs practicing training in a rural setting. That's about 70%. But when we talk to the programs themselves, they're frequently talking about the challenges of having clinical sites for students to visit. So again, thinking about not only the slots and the payment for them, but the infrastructure to support them, and then supporting our providers as preceptors or kind of mentors to them when they are in that site. Okay, so that's kind of some big picture stuff to mull over. I know you're like, okay, Carrie, I really want to know how do I get people in the door? And so from a federal perspective and kind of thinking at the national level, we've spent a fair amount of time really kind of thinking through within NRHA and within kind of our federal workforce strategies, how we grow this workforce that we need and how we support it. So we have kind of 3 different areas of how we think about this. So the first is the need to increase the number of health professionals. And this is everything from kind of, like I said, increasing and strengthening those training experiences, making sure we're paying for them, making sure we're offering opportunities for foreign trained providers to practice in these settings, and then supporting programs like the National Health Service Corps, the Nurse Corps, other kind of state loan forgiveness programs that provide scholarship and loan forgiveness, so that as we train these individuals, we're also then placing or distributing them in underserved rural communities. So the first way we think about how we improve the issue of rural healthcare workforce is by increasing the number of health professionals. The second is to think about how we really support rural healthcare workers in the space that they're at. So part of this is around kind of making sure that these folks have adequate reimbursement and payment to be able to practice in these sites. We think about policies and programs that we can put into place to really support, honestly, quality of life and the value of that individual in as a community member in the rural setting. And then, especially coming out of COVID, what kind of policies and programs do we need to support kind of the mental health and resiliency of these individuals, especially when we know that practicing in some of our most underserved rural settings can be quite challenging and isolating to many folks. And so what are we doing to kind of support our workforce psychologically and socially? And then the third bucket of kind of how we're addressing and how we think we need to address the rural workforce challenge is thinking about how we modify a system that is frequently more of an urban structured way that we provide care to make it work in a rural setting. So thinking about kind of, for example, telehealth. Coming out of the pandemic, we saw a huge growth in telehealth in both rural and urban settings. So what did we learn? What do we know? What can we maintain from the current telehealth flexibilities to be able to support our rural workforce and patients moving forward? We really need to think about how we are doing innovation and demonstrations in terms of building our rural workforce. So thinking about really a multidisciplinary approach to care, knowing that, for example, we have good access or better access to physicians and assistants and nurse practitioners and some of our mid-level providers. So how do we then have that as maybe one of our linchpins with our family physicians as our providers in a community, and then build a team around them, whether that's access to specialty care, whether that's using community health workers in kind of a care coordination role, but really doing demonstrations to think about kind of what does that care team model look like in a rural area. And, and then as we work with folks like the Centers for Medicare and Medicaid Services or state Medicaid programs, thinking about how we pay and fund through demonstrations and other innovations, those kinds of workforce models that work, that function well in a rural setting. Okay, so that's big picture. And a couple examples of what's happening in Washington, what we're tracking on day to day to help support kind of those three big philosophical buckets. So the first is kind of our regulatory side. So these are things that are happening out of the executive branch and mainly out of CMS, but some HRSA, all out of the U.S. Department of Health and Human Services for the most part. So the first is, and hopefully you all have been spared from this and kind of thinking about what the challenges are for folks, but HRSA recently has been trying to more significantly kind of update their shortage designations, and there are a lot of states where this has been a real pain point. We were successful in this last year to get kind of a year delay in or a pause in any designations of health professional shortage areas, but obviously, shortage area designation is important not only to recognize the challenges of that community, but to bring in resources tied to that. So we're following closely on kind of shortage area issues and working closely with HRSA on kind of trying to figure out how we can make sure that the policies don't harm our providers and our facilities in a time when we're already stressed with kind of post-COVID inflation kind of workforce challenges. We also know that HHS as the department has been thinking through kind of what they can do to strengthen primary care. And so they have a new initiative that they've been putting or that they are starting and starting to put in place. And NRHA has been working with them to make sure that the rural lens is definitely part of that. And then last but not least, really thinking about as we come out of the public health emergency, as we anticipate it winding down at some point here, we're hopeful, like I said, that there will be a continuation of a certain number of the waivers and flexibilities that we've seen for the last 2 years, and thinking about where it might make sense to make some of the staffing or workforce related waivers a permanent policy change in order to just provide a little bit more relief to our rural facilities and communities. So a sample of kind of what we're talking about in the regulatory space on this issue. And then, and then 2 more obviously big payment regulations. The big daddy of all of the workforce training is really around graduate medical education. I'm not going to spend too much time on that because I know as critical access hospitals, you likely don't participate a lot, if at all, in GME training. But that's another area where we are really trying to influence as new slots are opening up, that they're going to rural areas, and that they're being allocated in a way that really allows us to get that maximum rotation into rural communities that we talked about early on, because we know it works. In terms of the legislative space, we have a number of things we're working on. We always spend time talking about appropriations and the base funding for our workforce training and distribution programs that are funded out of HRSA. So I'm lifting up a couple of here, but this includes all of kind of the physician and nurse and advanced practice kind of training programs. From our perspective, 3 that we talk a lot about are the Rural Residency Planning and Development Program out of the Federal Office of Rural Health Policy that I mentioned, that really helps to support the infrastructure so that residency programs can start in rural communities. The National Health Service Corps and Nurse Corps as our loan repayment and scholarship programs for a distribution effect to rural. And then our area health education centers, our AHECs in states, which really provide kind of the glue for a lot of our workforce, both physician all the way down to allied health in a state, and thinking about kind of how we connect those individuals, that training, to our communities of need, especially in rural areas. So appropriations, making sure we have the budget to run those programs and get those grants out to our rural communities. We also are looking at issues around kind of what's allowable by providers or for providers to do in like in the clinical setting under Medicare and Medicaid. So the Improving Care and Access to Nurses, or ICANN Act, really looks at some of the what I think are outdated kind of regulations around what advanced practice nurses can and cannot do, and removes some of those barriers. Obviously, scope of practice tends to be a state issue, but it kind of is along those lines of allowing greater flexibility within Medicare for some of those advanced practice nurses knowing, and physician assistants knowing how important of a role they play in rural areas. I talked a little bit about GME. We have a bill right now, the Rural Physician Workforce Production Act, that really thinks about restructuring GME in a rural setting and thinking about kind of what does it mean to be rural? How do we pay our providers like critical access hospitals and sole community hospitals so that they can participate as training sites for GME? And then just how we actually pay for the GME payment itself in a rural setting. And then the third program I listed here is thinking about, this is just an example, the Conrad 30 program is an example of how we incentivize and bring foreign trained practitioners into our rural communities. I'm just going to pause real quick and make sure you all can still hear me because I'm getting kind of a low internet message.
We can still hear you, Carrie.
Okay, perfect. Okay, so that's kind of a sample of what we're working on in the policy space. in trying to address issues around workforce shortages and growing our rural workforce. So federal resources in this area, I've mentioned several times the Federal Office of Rural Health Policy. Hopefully you all are familiar with them, but if not, I suggest you look that group up. They are a fabulous voice for rural health at the federal level within the U.S. Department of Health and Human Services, although I am totally biased because I used to work there and I think they're a fabulous bunch. But they do some really important work, being a voice, like I said, for rural, really thinking about how they can partner with other parts of the department, like the Bureau of Health Workforce, to put out programmatic activities, grant initiatives that really help to bolster not only the physician, but kind of the public health, the health IT, HIT kind of workforce in rural communities. And they've done a broad range of programs, not only out of the federal office, but out of kind of the partnership with the Bureau of Health Workforce. Right now, I think I talk about this in just a minute, but they actually, the federal office does have an open workforce grant opportunity right now. So I wanted to spend a minute just talking about that. The other thing that the federal office does is in that research space. They help to fund our research centers, so we understand kind of what are the gaps, what are some of the root causes behind the gaps, not only just the supply numbers, but they've done some real important work around looking at kind of subpopulations, both racial and ethnic diversity of populations in rural, knowing that that is an important tie for people to be able to access care sometimes. And then also kind of thinking about how do we grow workforce in certain areas, like when we talk about the opioid epidemic, how do we get more providers engaged in MAT and other kind of treatment programs? So they're really able to hone in on specific issues and figure out kind of what the issue is, what's happening. And then we take that to the policy space where they comment on regulations that I just mentioned. They work with the Centers for Medicare and Medicaid Services to develop provider payment models. So like I said, this is a really important resource and tool for us as we think about kind of our federal and national workforce development. More at the provider level, I wanted to highlight a couple of different things. So Rural Prep, which is the group that I talked about that's doing kind of the research on how we're training individuals in a whole range of healthcare professional fields. They also have some really good teaching kits and resources about things like, for example, precepting and how you might be able to grow your capacity for precepting, how you can learn how to precept our students as they maybe come into your setting. They have some good resources on fostering interprofessional collaboration. So kind of within your facility, your system, and then thinking also about communities of practice. So you might not have to learn from how to precept from the ground up. You might be able to learn kind of some best practices on K-12 engagement from another rural community that's part of kind of the larger conversation. So I recommend checking out Rural Prep. I'm happy to connect you guys either directly or kind of at the state level if that's helpful. And then I mentioned workforce funding. These links, when you get the slides, they all should be active links that will take you directly to these notices of grant opportunity. But these are just a handful of those that are really rural targeted and getting specifically mentioned, getting folks to our rural communities. And the one that's up right now is the Rural Residency Planning and Development Program. So this is the program that provides resources for a community to come together with a hospital or another healthcare institution to develop a residency program. But all of these programs can be used in different capacities to build your ability to host or train students. And you can find out more about all of them, like I said, on the individual links. I also put a HRSA's grant like finder link on there with workforce teed up so that you can kind of browse to see what else might be available in the broader kind of workforce sphere. Hopefully you all know about 3RNet, but if not, I wanted to make sure I spent a minute on it just in case. So 3RNet, which is the National Rural Recruitment and Retention Network. When I was in the Federal Office of Rural Health Policy, we helped to fund these guys, and I always used to joke that they're kind of a rural dating service between a clinical provider, someone looking for a position, and then you all as a facility. Basically, it's a website where health professionals can specifically look for jobs in rural areas and underserved areas. It's free for the health professional. I believe it's either free or greatly subsidized for the healthcare employer. You can post your job on their network for students and others to kind of check out. And they've got some good resources in terms of recruiting for retention and other kind of best practices for bringing and keeping people in your rural setting. I will say, you know, they have a great track record for helping with this process. They have kind of, I believe, over 2,000 placements that they do every year. And the vast majority of them, like in the 80-90 percentile, are in rural underserved. So these folks know their stuff. And if you haven't checked them out, again, these are live links. So I would recommend this being a good resource for you. Okay, hopefully I'm not boring you to pieces. Here are some pieces that are some strategies and best practices. This is kind of, I think, what I've heard, again, lessons learned, both from research and talking to others about what they've done to attract individuals to their facility. So a big part of the successful recruitment of health professionals, students, and individuals, I mean, I hear this all the time, is really starting young, right? So starting early, really all the way down to that like K-12, here they have K-16, I think that's taking you through undergrad, but really just everything from kind of going to the schools, sharing like at job fairs or working with you know, the science teacher to have, you know, someone from your facility come in and talk about healthcare or what you do in your facility, getting them potentially into your facility on a field trip or some other way that they can kind of get exposure to a clinical setting and what it's like to be a healthcare provider. As they get a little bit older, you know, opportunities to mentor or volunteer in the hospital or the healthcare setting, all the way up to kind of actually helping to fund or support readiness programs, whether that's kind of tutoring, partnership, like I said, for like internships, helping them apply to school. There's all sorts of things that we've heard about in terms of kind of strategies to get students connected to rural health careers. So again, it's kind of that motivation or healthcare awareness. So presentations, career fairs, maybe summer camp, you know, something where you can partner with someone else in the school system or other community-based setting to build awareness. The exposure through like a field trip or a site visit, some kind of shadowing kind of opportunity, and then like the mentorship as well. That kind of fits in also with the internship or shadowing. Just really helping rural kids to see their future in healthcare seems to be a huge kind of initial hook to bring people into rural practice settings. Another tool that was lifted up to me was or is the Community APGAR program. So this is a program that was developed in Idaho, and it was specifically developed to improve a rural community's recruitment and retention of a whole range of folks in the healthcare setting. So family practice physicians, nurses, as well as like that hospital leadership kind of level, and for a variety of settings. So critical access hospitals, rural health clinics, and community health centers. And what this tool does is that it's a process, it's a planning process that you as an institution or as a community would go through. And it helps to identify and weigh factors of importance to the community around bringing in this individual. And then once you've identified those, helps you think about kind of what you can do in the planning and improvement stage to make that happen. And so this kind of use of this tool happens before recruitment efforts would ever begin. So before you place your ad or work with a recruiter or work with 3RNet, the experience from Idaho really says that you should spend some attention on planning and preparation, and that you'll have much more success in the end. So the planning process looks a little bit like I said, assessing what the community need is. So who is the individual that you're trying to bring in? Making sure that you have buy-in from other community members to help that happen and to help them understand why it's important for you to have this physician or NP or hospital leader within your community, and helping them to kind of think about what role they might have in recruiting and housing that person in the community. And based on that, having interested parties become part of a committee to work on the recruitment and retention. I would say this probably this doesn't have to be a one-time thing. Obviously, if you've spent time developing this can be a committee or a group that you keep together and revisit. And then thinking about not only the recruitment process, but how are you going to retain that person when they come? So thinking about what that might cost in terms of budgeting, thinking about what you can talk about or offer within your community to improve the quality of life of the individual when they come. So if they have a spouse, thinking about what that spouse might be able to get connected with and how you might assist in that process, or thinking about kind of schools and other things, just helping to negotiate or navigate that for a potential candidate. And then actual thinking through what a site visit might look like. Again, how can you help make that connection? How can you help make this, how can you help talk about how great rural is to live in terms of the quality of life? And then, kind of just always doing a reflection process as part of that. If it didn't work out, what happened there? And just continuing to build on and improve that. And I think a big part of this, I'm from Montana. I am a multi-generation Montanan. And so I feel like I understand what it looks like to live in rural areas. You guys understand what it looks like to live in a rural area, but we don't always, and as someone who says the older, sicker, poorer adage a lot about rural communities, we don't necessarily always take the time to talk about all the good things that are happening in our rural communities. And that's obviously very important when we talk about rural practice. And so I think being able to articulate and really highlight the rewards of practicing in a rural community, why your community is so wonderful to be a part of, why do you live there? So thinking about kind of that draw to mission, the relationships that you have with your patients and your colleagues, thinking about that quality of life. For a lot of folks, it's an autonomy issue, right? So I worked in Alaska with folks in Alaska, and we always talk about how it's a rare breed that's attracted to work in Alaska. They like the Wild West. So really thinking about those kind of things. What can you offer that might be attractive to a person? Is it a leadership opportunity within the community or the facility? Is it an opportunity to to teach or precept? Is it some kind of financial incentive that may make paying off their loans easier? Really thinking about kind of and being able to articulate what your community can offer in terms of practicing in your setting. And then I know I have to mention compensation. I know that this is very challenging, and I know it's just brutal right now with inflation and kind of where we are with salaries coming out of COVID, and just there's a lot of challenges here. But I wanted to share kind of what was shared with me in terms of what makes up a desirable compensation package. So you've obviously got your kind of your insurance benefits, the pretty standard stuff, professional benefits. So thinking about kind of what does call look like? Can you pay for any associations? How can you help them with malpractice or licensure fees, that kind of thing? It's not unlikely that you will have to think about some kind of bonus structure, both initially and in a retention kind of capacity. And then when you talk about some of those other community partners that would have been involved in your APGAR process, thinking about what else can your community offer to support this individual. So is it, how do you get them hooked up with a house and home loan? Again, how do we find something for their spouse to do? Is there a daycare or good school you can help them get connected with? All of those kind of things I would put in a compensation package, right? You're really trying to put your best foot forward to bring these folks on board. And then after we've spent all of this time bringing them on board, we really want to think about how we best retain them. And we know that job satisfaction is very closely associated with higher retention rates, and that if folks are feeling isolated or frustrated or stunted or not supported, they're less likely to stay. And while, autonomy is something that brings, I think, rural healthcare workers into a setting, they still need to feel connected and supported in that process. And so factors that can influence that kind of retention include kind of career development opportunities, thinking about kind of that community connectedness, and how do we keep that provider connected in a more patient-centered way, provider-centered, patient-connected way. Think about kind of, I know finances are tight, so thinking about how you might be able to tap into grant or other kind of funding opportunities to offer education or professional development to those individuals so that they still feel like they're growing in your setting. And sometimes it really is just kind of that making someone feel like part of the community, right? So if you feel, and I'm from rural Montana, so I get it, that can be challenging, but it's important for people to feel like they are part of a community, they have a sense of belonging there. And so thinking about what you can do to help kind of acclimate and support them in that transition into the community. And again, that's why having this community kind of collaboration is so important, because it can't just be you as the facility. It really is important to think about schools and other kind of aspects of this. And then I would say the other piece I haven't spent a whole lot of time on, and I probably won't, but I just want to throw in a pitch again, that telemedicine can be an important piece of all of this. I think a lot of times when we are talking about telehealth coming out of the pandemic, we're talking about kind of that patient to provider connection, but that provider to provider support through something like a Project Echo or some other kind of method can be a really important tool to combat kind of that isolation that I think a lot of providers feel. And so thinking about how within your state, within your community or your region, you might be able to tap into some of that kind of professional collaboration, and maybe through telemedicine as a way to just kind of stay grounded with each other, as a way to retain folks. Okay, that was a lot, and I've talked for almost 45 minutes straight. So I just want to do a couple minutes on what it looks like to advocate for advocate with NRHA. All of those federal things that I talked about, I just wanted to share some resources about how you can help us move the needle. These are not all workforce specific, but we do anticipate a big kind of appropriation omnibus package at the end of 2023 that would have workforce training as well as some non-budgetary issues like sequestration and telehealth and Medicare extenders included in there. And so we'd love for you to help us talk to our policymakers about why this is important and why they need to support these elements in the end of year package. We've got some talking points for you to help you with that process. You can either do that verbally or via email. We have pre-drafted emails you can use. If there's a topic within workforce or more broadly that I didn't talk about today that you're interested in, we are logging all of the bills that we endorse on NRHA's legislative tracker. So feel free to check out that resource and let us know if you have any questions or anything that you don't see that you think we should be doing in the legislative space. And then the other plug I would make, and I know we're kind of getting to almost the election time, but now is a great time to connect with your elected officials because so many of them are out campaigning or in the state during this recess that we've had around the midterms. So, connect with your folks, let them know what's important to you. You as a constituent have such a powerful voice. And our job is to have resources here to support you in your advocacy. So sign up for our NRHA Rural Roundup, follow us on social media, let us know if you need any specific tools or resources because we are here to help. And one last plug for our Policy Institute that's happening in February. If you want to come learn more about what we're doing on workforce and kind of all issues facing rural communities, we have members of Congress, members of the administration come and talk with you, and then you get a chance to talk with them at our event in February here in Washington, D.C. And with that, I will stop talking. I haven't seen any questions or comments come in the chat, but I'm happy to take any as folks might have them.
Thank you so much, Carrie. One question that came in was 3RNet. Can you go into maybe just a little more detail as to how individuals know to go to that website to look for a position?
Yeah, let me, so the way I understand this to work is that as an employer, you would contact 3RNet and you're able to kind of post your jobs. And then there are actual kind of 3RNet coordinators that can help with that kind of dating matching service. And then as the professional, the clinician is interested in a position, they can get on and they can search kind of by location or by type of position. And then it'll like the site helps to match you in that process. So I don't know if that, hopefully that kind of answers the question. I'm going to drop the web link or the, what do we call that, web address in the, I don't know if this will go to everybody. This might just go to the hosts, but
We'll make sure
if you can check it out. Does that help?
Yes, I think so. I'll watch for additional questions from that person. The next comment was the toolkit for the K through 16, or is there a toolkit for the K through 16 strategies, kind of outlining some different approaches?
That is a good question. The information I pulled from it, I didn't have a specific toolkit on that. The toolkits I had been talking about were more, I'm not sure everything that's available through Rural Prep, but let me put their e-link in there too, and I can ask them if they have any kind of K-12 specific tools. I feel like the AHEX might be good at that too, so we could see if they have any there. Any other questions?
Kind of around travel nurses. Are there any studies going on around the impact that travel nurses is having on rural communities, both in needing to utilize them as well as pulling rural nurses away?
Yeah, that is a great question and spot on in terms of what we heard during the pandemic and coming out of the pandemic. I will say, the issue of travel nursing I'm hearing less about it, but I'm not aware of a specific study that's happening right now. There is a bill that we have endorsed that would have the federal government look at the issue and look at what potential solutions there might be to addressing that kind of issue moving forward. So let me drop that bill number in the chat. That's probably as close as to what I've heard as a formal study, but I can take that idea back to some of the Federal Office of Rural Health Policy researchers and suggest that to them. I participate in their brainstorming calls, and so I'm happy to bring that back to them as a need, because I know from kind of the policy standpoint, it was hard to figure out at a national level where we could really influence the traveling nurse issue. And so, yeah, it's a great point. And I will drop this bill number in here and then take that back to the research centers as an idea for a future study.
Thank you. I think that's
Yeah.
helpful. What other questions are out there? And again, pop them into the Q&A or the chat, and our team will pick them up, or definitely raise your hand using the raise hand icon and we'll unmute your line. So we'll pause here just for a minute to see if there are additional questions. Lots of good information, lots of good resources. Tough challenge right now for all of our hospitals.
I know. And that's why I was kind of like, oh man, I wish I had the solution here. And I would say also, if any of you have had successful practices that you can share, would love to hear some of those too.
And Allie, I'm not seeing any questions coming in right now. Have you had any come to you?
Nope, that was all.
Okay. Joyce, I'll turn it back over to you. Oh, go ahead.
I was just going to say my contact information is on the slides, and folks should not hesitate to reach out. I am happy to help wherever I can with workforce or any other kind of issue. I'm just so thankful for everybody out there on the front lines doing this work day to day. And so whatever we can do to support you all, we're here.
Great. Thank you so much.